All right, so welcome in the sim room. Before we do any sorts of simulations, we want to make sure we bring you in here and we show you the equipment, the room, what we expect out of you, and kind of give you the ground rules on what's going on every time you're doing a sim. Most everything is going to be about the same. Most of the ends of my sentences are do what you do in real life and you're going to be fine. So if you have a question as to what we want you to be doing, what would you do in real life? If you do that here, you're going to be fine. So to start out the ground rules, the 3 words you're not allowed using in any of these sim rooms are simulate, pretend, and with a real patient I woulda. Do or do not, there is no simulate. We want you to treat this as real as possible. With your interactions with the patient and what you're doing, we want you to do everything. That also falls under the category of there's no talking to God. So there's no fair doing one of these, what do I see, O Lord? God's not going to talk back. He doesn't have this number. And the patient's going to kind of wonder about you, just like in real life. So anytime you need to talk to somebody out here, we're going to treat this like a speakerphone. You know, I happen to have a phone in this room. Not all of the sim rooms do. But what I want you to do is if you need a physician, if you need, somebody outside of this, your preceptor, you're just going to treat it like a speakerphone. Hey, I'd like to talk to the physician if I can. Now, you may or may not get a response, and they are not waiting by the phone to talk to you. So until you get a response, keep doing what you do in real life. All right? So that's kind of some of the starter rules, and then we're going to go on the mannequin from here. We have lots of different mannequins. Before we put another mannequin in this room and expect you to do things with it, we're going to give you an orientation to the mannequin. They're all a little bit different. They all have some more features, less features, different features. So this is a high fidelity mannequin, and that's kind of fancy words for looking to the mannequin for all of your cues. Notice there's no faculty in here to ask or anything like that. If I want to know whether this patient is breathing or not, I'm going to look for chest rise and fall. I'm going to talk to the patient just like a real patient, and they're going to talk to me if they're alert and oriented, okay? So I can look for those level of consciousness indicators, look to whether they're breathing, listen to whether they're breathing, and things like that. As far as lung sounds on this mannequin, they've got lung sounds all over the front of the chest here where you'd normally listen. Make good connection with your stethoscope and you should hear it. If normally you would listen on the back, this mannequin doesn't have posterior lung sounds. But say another simulation we have in here where they do, you're going to actually set the mannequin up because obviously they can't set up themselves. That's usually why we bring you in here in groups of 2, 3, 4, something like that, is so you have that help. But lung sounds are all over the chest, the front of the chest on this mannequin. Make good connection with the stethoscopes. Pulse points. So on this one, we only have it on the left side. The right side is just an IV arm, so it's got all the fluids, no electronics in this arm over here. So you can feel around for a pulse, but there isn't going to be one. That doesn't mean the patient's dead. That simply means this is just the IV arm. So if we go on to the left arm over here, you feel around for something squishy, press down, lighten up, and you should feel a pulse. Biggest thing I see people doing is they'll go like, I can't feel a pulse. Okay, lighten yourself up, lighten your hand up, and you should feel it. The other thing is, you want to feel for a pulse for a full 10 seconds. If you do not feel a pulse, you're going to do some really awful things to this person, right? Give them their full 10 seconds. Make sure it's not a slow Brady or things like that. The other thing I like to do is get kind of buy-in. I don't feel a pulse, do you? It gets another clinician in here, one of your team, to feel and kind of have that double check. Then if you don't feel a pulse, you're going to do some things. On this mannequin, like I said, we have a radial, we have a brachial, and he has carotids bilaterally. You're going to go a little bit deep, a little bit high, and feel, and there you go. This guy doesn't have femorals, doesn't have pedal pulses. Some of our other mannequins do. But all the pulses are about the same. You want to press down, kind of lighten up, and feel for it. So speaking about neurological checks, obviously, this guy doesn't blink. Some of the other mannequins we have do blink, maybe even have pupillary response, but this one doesn't. His pupils are fixed, but when you indicate them or when you go by with a light, I'm going to give you some sort of response to tell you whether things are good or not. Whatever they are is what you've got. You don't need to like interpret or feel like or think about what do they mean and that sort of thing. So speaking about moulage, which is the fancy word for the blood and guts makeup and things like that, I'm going to make it pretty obvious that something is wrong and you need to do something clinically for it. But pupils, this one here are fixed. You're going to check them. You're going to get a response from the patient and you're going to go on. Other neurological checks, you're going to do whatever you would do in clinical practice. So if you would do the touch, do you feel, he's going to respond to you. If you want to do the one person, grab on both hands and say, can you squeeze evenly on both sides? He's going to say, I'm even on both sides, or I'm a little bit weak on the left, or something like that. But I'm going to give you those responses. I know it's a little hokey, but it's things you would need in your clinical practice to differentiate different types of care, so I have to give that to you here, okay? Speaking of sim-isms, I also don't want you to overtreat, okay? Only do what you would do in your clinical practice. So this is not your time to show me that you can do a 20-minute long neurological check. Do what you do in real life, and you're good. Usually going on from here, I talk about, if we're going to place a Foley, if I've put urine in the bladder or things like that, or what response is. But from this point on, I invite everybody over to feel pulse points and to listen to lung sounds. And this is really important. This is their time to figure out where the pulse points are, feel it, and that sort of thing. They're very nervous, and they don't want to, feel like that they have to ask questions and things like that. But if they don't feel them here and then they can't find it in a scenario, it's going to cause problems in your scenario. So I invite every one of my learners to now is your time to listen to lung sounds, feel pulse points, and ask your questions. This is normal. Anything outside of this is going to be abnormal. So I usually step back, make sure that everybody puts their hands on the mannequins, asks the questions and things like that. And I shut up. And I make sure they're doing this and having their conversations. Because then usually something I may have forgotten in my orientation, they'll mention something and I can then add that in when they're done. At that point, I have everybody step back and I'll go through any other unique things for this mannequin, go over the ground rules, what I expect, what I don't, and that sort of thing. From this point on, we go over bed controls because all the beds are a little bit different. Usually I tell them they have to have it powered on and use the right controls. I'll go over the CPR thing. And then I'll usually say is, you may not need that today, but because you'll need to know this when you're working in the field, I want you to know that there is a control on here to drop the head of the bed for CPR purposes. After that, I usually go over the head wall. Okay, so a lot of my sim rooms have this style horizon head wall, and I make sure they know that the compressor's on, everything's going to work like it is in clinical practice, and I expect you to do it here. So if you're going to put an oxygen device on this patient, I expect you to connect it, dial in the dose, and actually do it. And the other thing I talk about is this is the time where we talk about closed loop communication. Because in clinical practice, when you're working with a team, it's good to use closed loop communication. Hey, can you put 2 liters nasal cannula on the patient? Sure, I'll put 2 liters nasal cannula on the patient. Do it. 2 liters nasal cannula is on the patient. It allows everybody to know where we are, and now allows people to know what events have happened. And I tell them in sim, it has an added benefit of I can hear what you're doing, therefore I can make the patient respond appropriately. I go over the suction, how that works. I'll go over oxygen devices, flow rates, things like that. Then I always talk about my code blue. Now on this head wall, that's not a button, it doesn't do anything. But I tell them, you have to actually walk up and hit it. You can't actually just motion towards it, because I see that sometimes. But I also tell them, closed loop communication. All right, I'm gonna call rapid response. I'm gonna call code blue. And then usually you're gonna get a response overhead of, this is rapid response. What do you need? Make them do that emergent communication over S-bar. Or code blue, they're gonna hear code blue. Okay, and then keep doing what they do in normal life. From that point on, I usually go over to the patient monitor. A lot of our scenarios, we have patient monitor because these are the indicators that they would be looking for to fully diagnose or give that full clinical presentation. So we like to have it on for a lot of our sims. So I talk about the ECG rhythm, and I have patients or students of different learning levels and things like that, and they may know what it is and they may not know ECGs. And At that point, I always talk about that you may not know all your ECG rhythms, but you know that's normal. And outside of that is abnormal. And you might want to do something about that. So you need to realize what is normal, what is not normal. You don't need to be that expert yet, unless they do, and then ECGs are on them. You have a heart rate that will hopefully correlate with the, pulse we feel. We have a pulse ox waveform that does most clinicians no good, but they have that number, that pulse ox number they're looking for. The other thing is I always put T blood there, okay? And normally when I start it off, it's turned off, and it's like that. At that point, I tell them, I'll point over to the temperature probe in the corner, and I say, I want you to do everything normally you would do. So tell your patient, I'm gonna stick something in your mouth, I'm gonna do this, can you put it in your tongue, things like that. And then I say, if you temp the Manikin out, it's gonna get room temperature. So from that point on, you're gonna actually look for your reading to pop up right here. And I'll be in the back room and I'll do that. But I want you to do everything you do in real life. Like the glucometer, I want you to take it out, I want you to come over, I want you to use this, stick the patient's finger and actually look for a reading. Now, there's probably gonna be something taped to the front. That's your reading, and that's good. If not, I'll find another way to get you that number. But I'm not gonna overhead do voice of God. Just kind of go with it. From that point on, we talk about the most lied about vital sign in the world, and we say, how do you find a respiratory rate? We count them. Unless I'm working with a real patient or a real person, and therefore I always say go with that number. So you want to tell them the differentiation of rules off the normal Manikin rules and people rules or something that might change for this sim. So because I'm not going to make my real standardized patient hold their breath for the entire sim if they're apneic. Go with the vital signs that are here. What you see here is right. From that point over, I try to always put a blood pressure cuff up here that automatically cycles every 1 minute. Now, some people like to have manual blood pressures taken in their sims. That's fine, you don't have to have this. I just think that it's a good time, or it's not a good time to teach them or test them on taking manual blood pressure, because most times in clinical practice, they're using an automatic cuff. And then I usually have this cycling every minute because then that gives them a trend. They're nervous, they're scared, they're not going to cycle it as often, but we want to give them those clinical cues that we might have a change off of baseline, and so that works. So go over mostly all of the patient monitor, ask if they have questions. Asking questions is important because until you really get your orientation down, or even when you do, you're going to forget things. I forget about belly sounds all the time. People will be like, well, what about bowel sounds? And then I talk about my bowel sounds, or I'll talk about different things that I've forgotten. So make sure it's a two-way conversation and you're getting feedback from them. Once we've gone over the Manikin, the bed, the head wall, and the patient monitor, we just kind of go around the room. I talk about sharps containers to make sure if there's a safety on your needle, use safety that and that sort of thing. My clean gloves, my alcohol wash, my sinks, things like that, and all those important things that we expect them to do. I tell people, I wouldn't touch a patient without gloves on. I don't know why you would either, but I expect you to do everything you do in real life. Other things I talk about are things like, if you open a drawer and you don't have the supply you need, what would you do in clinical practice? Most people are going to call central supply, or they're going to go to the supply area, but I tell them they don't have to wander away for sims. All they have to do is call central supply for the supplies, and I'll get it. And usually at that point, I'll tell them, now realize your voice for the Manikin is probably running down the hall to get you that supply. So if you go to talk to the patient right after and they don't respond, they're not dead. It's just, give me a minute. I'm getting your things. Then any other things like, they don't need to act for anything. They don't need to simulate. They don't need to pretend things. I've had students, when this patient asks for food, I'm hungry, they will come and fake a bowl of soup and they'll fake give it to them. And if I'm the Manikin, or if I'm voicing the Manikin, I'm going to say there's nothing there. Because again, do or do not, there is no simulate. We want them to do everything. If it's not in the room, it's not in the room. I always tell them on anything, they get what they get, and that's what they've got. If they don't have it in the room, it's not there. So those are the basics of the orientation. It's really important because it will actually change depending on how you see them react in a simulation. Case in point, we had critical care sim where when they went to bag, they were not bagging appropriately. And what we found was that they had not learned bagging or not touched a bag in over a year. And some skills are very perishable. So we added that to the orientation of how to bag. And the very next sims, when it came to that point, when they realized they needed to, and the reasoning and clinical reasoning skills of why they needed to bag, they did it. But then, of course, they bagged from the side because I didn't teach them, oh, you want to unlock the bed, move the bed, go behind, that's the appropriate place to bag. So pay attention to how your sims roll from your orientations, and you might need to add and subtract things. The other thing you're probably thinking of is this takes a while. And for an initial learner group, yes, it does. And that's okay. You need to add that time into your simulation. It's very important. Because if you do an appropriate orientation and people know what to expect, they know where things are, they will actually get through a simulation quicker and more efficiently. Not because we're giving them the answers, but we're taking away a lot of those stumbling blocks that aren't in real life. And then you'll find you can add more clinical reasoning skill items into your simulations. The other thing is people will say, well, do I need to do this every time? Yes, to a point. If they were just here last week, you may need to just go over some of the rules again. Remember, no simulate, no pretend, no talking to God. God doesn't have this number. Do everything. When in doubt, do what you do in real life. I tell them, I'm like, if you were truly lost on the floor tonight, what would you do? And usually there's some murmuring and I make them answer. And they were like, well, I'd get my preceptor. Great, you can do that here. I have anything that they would use in clinical practice, they can use here, because I tell them that there's no fair in saying real, but you can't bring your drug book in. Anything you do in real life, you get to do here. And that's how we approach it. You may do it a little bit different. But any way you cut it, it's one of the Enaxle standards of best practice to do an orientation to the room, to the equipment, and out of what you expect every time. And a lot of that has to do with showing them the equipment, but also unpacking sim baggage, making them feel more comfortable with the room so that they engage better and they learn the clinical reasoning skills and all of the things we want them to get out of sim. So that's why it's important to me. That's kind of how I do my orientations. I hope you enjoy. Thanks a lot. Have a great day.